I went to CMS, that's what I challenged the 5,500 people in CMS to do. I said, you're not here to write checks or to do survey and certification or to write Medicare state waiver letters. You're here to provide for the 100 million people who depend on us better care, better health, and lower cost every single day, no matter what you do. Now, I have a reason for pursuing that personally, which is I think healthcare is a human right. And I think this is the only nation in which we have not made that so. I think we're on a majestic course right now in which it is now possible. I'm proud to be in a state in which healthcare is really becoming a human right. And I agree completely that we did the right thing to try it, and now we have to, we always get to the next problem, and we're trying to solve that problem now. But that's what I'm interested in.
One might think of the healthcare system as sort of a runaway freight train, kind of going down the tracks, and it's going too fast. And Medicare and Medicaid maybe this is sort of the metaphor that's often thought of. Medicare and Medicaid are sort of attached at the end of the train and are just being pulled down this track at a very rapid rate by an engine. And so in some ways, Medicare and Medicaid really aren't the problem, so to speak. They're just part of this larger system that's going too fast and needs to be slowed down entirely. You know, the whole train needs to slow down. Now, the metaphor has a certain semblance of truth to it, except there might be a little twist, which is, what if Medicare and Medicaid were actually not at the end of the train, but we're actually at the front of the train, and we're two engines pulling the rest of the system down the track at too rapid of a rate?
Coverage is key to the improvement of better care, better health, and lower cost. But the other part is what I want to chat about, which is that improvement is the key to coverage. That is, it's manifest that the current system can't be supported, not without taking a lot of important things away from people, whether those people be students in schools whose class sizes rise because of health care, or talent development in arts, or corporate profit. That is, we can't provide the kind of equity in access in health that I would like to see if we are stuck on the system as it currently performs. It sums to $11 trillion over 9 years. There's nobody on any side of the aisle in the reddest part of the country that's looking at anything like $11 trillion of cut. We would solve the American healthcare problem by summing to $2 trillion of waste recovery over approximately the same period of time. Andy and I calculate 4% reduction in waste, annualized, compounded, over 10 years, we're done. We can go on to some other sector. In my work as administrator, as Tom knows, your day is full with people bringing you things to sign, regulations, waivers, state Medicaid director letters, and so on. I just wanted a cover sheet on everything. Every time I looked at something, I wanted to know 3 questions. What will happen to patients? What will happen to the poor? And what will happen to cost? Because if I know these things, I can get the regulatory environment oriented toward the 3-part aim. Now, I've glossed over a lot. I haven't talked about the economic dislocations that would be implied in real waste removal in the system. Believe me, I understand the political obstacles probably as well as almost anyone right now. Yes. But this is the agenda, to migrate toward an American healthcare system, not a Medicare and Medicaid system, an American healthcare system that respects the 3-part goal of better care, better health, and lower cost, and takes advantage of the removal of non-value-added activity as the center. Now, whether we can do that is a different question for the nation. This is how I think we need to proceed. I think the guidance for policymakers, for the professions, about how to get it done is this. First, the patient has got to come first. The whole discussion of rationing and death panels and takeaways and rescissions, I don't think we need to tolerate it. I think that it is quite possible to have health care, all the health care that everyone wants and needs, I will say. I think as a moral obligation, it's got to be done by dealing with the needs of the poor first, and I look to any leader in our country to say that it is a claim to be made, and I don't care how the polls show. If we don't do that, we've lost the game.
If you look at what was passed in the health care law, there's lots of discussion about delivery system reform, fixing these problems in American health care. And the lever they're trying to pull is, number one, through the Medicare program. In a sense, there's a recognition in the health care law that unless you change this dynamic in Medicare fee-for-service, all of these problems that we see in excessive cost, fragmented system of care, lack of coordination, you're fighting uphill if Medicare fee-for-service remains as it is today. But there's a cautionary tale around this, which is what I would call the Lake Wobegon effect, right? Which is that to really get to what we call delivery system reform, really have some bite and fix the system, you have to do really one thing, which is the number one thing you have to do, which is you have to steer patients away from the high-cost, low-value provider to the low-cost, high-value provider. That's a very difficult thing for CMS or the Congress to do because they kind of tend to take a view of the provider system a little bit like the parents in Lake Wobegon, right? Everybody is slightly above average. And the question is, who can bring that about? Can a governmental process lead that kind of productivity improvement in a sector as complex as healthcare? Or do you need some kind of market mechanism to make that come about? And I'm definitely on the side that you need a market mechanism, that the government's efforts in this regard may make modest progress here and there, but at the end of the day, if the government is really in charge of the resource allocation, they're going to be blunt and across the board. It won't be nimble, and you won't get productivity improvement. You'll get cost cutting.
What we really disagree on, that I think is I understand so much more after this conversation, is not what's broken. We actually agree on what's broken in the dynamics of, say, payment and delivery. What we disagree on is whether government is a good lead for trying to get things sorted out properly in the payment flows, and whether politically it would be possible to get that job done. The burden would be on me to prove that, because we have had failures politically, but I think government can do it.